All right, thank you. So hi everybody, I'm Jeremy. The dorm, I'm a CBT trained person, and the dorm did this thing that I really liked. They sent us all to get trained in MBT. I hadn't known a ton about it, and to say that our staff has been excited by it and our practice changed by it would be an understatement. So I'll just say, I'll give my short definition of the M in MBT, mentalization-based treatment. And this is not the official definition. This is my definition. This is how it makes sense to me. So if you already know about it, stick with your existing definition. If you came in thinking, what is MBT, another BT, this is the one I use. So I think of it as the cognitive and emotionally reflective work that the client needs to do. So it's basically when they're doing the work, that's mentalizing to me, when they're thinking about, when they're honestly reflecting on how they're interacting with people, on whether they're moving forward and thinking about things in a new way, that's mentalizing. Anything else they're doing is not mentalizing. If they're blocking, if they're being defended, any number of things they can do. So, you know, I'm an eclectic practitioner. I'm more of a jack of all trades. So adding this arrow to the quiver has been really helpful for me. So yeah, on the slide that you see right there, on the lower right, I was doing DBT with a client. So I know a little bit about DBT and a lot about CBT. And I remember giving one of my treatment resistant clients, I think it's actually, this treatment modality was created for people with borderline personality disorder and certainly works with others. I had such a client, and I remember giving her, you know, the Marsha Linehan book here. And I remember this is an actual sticky note. I asked her to put in sticky notes on the parts that she thought would be helpful to her, and she left this on my desk. And for whatever reason, I just love that this is stupid, but I did it, kind of a thing. For me, that captures the sort of the willingness and also the push and pull of the skepticism, and skepticism is appropriate at times. So I was looking for approaches that would work when I was hitting a wall with CBT and with DBT. MBT comes in perfectly for that. So I'm just going to jump right in. I only have 3 slides. Could you go to the next one? So I'm a visual learner, so I had to put a little GIF on there. That's my little hedgehog opening up. And I think the metaphor is like someone prickly and defended being given a sugar pill, and hopefully the defense is, you know, receding a bit. And I think in this case, the sugar pill would be genuine curiosity, but it is not applied generally. It is curiosity about what the person really needs to think about. It is curiosity about what the person's mental state is, what processes might be going on and might work, right? So in that sense, you know, we've all worked with people with BPD before, and we know that you don't confront them too early on, or you're dead to them, and it's a real hindrance to the treatment. So I wanted to differentiate between interrupting and confronting. Interrupting is something, the person who trained us is one of the gurus and founders of MBT. It's Anthony Bateman, and he has a wonderful British accent that I don't have, and everything he says has this gravitas to it. But he had a way of interrupting, and I really tried to copy his technique. What he would always do is someone would say something and they would kind of brush past it and start going into an old pattern of, you know, a line of blocking the therapist, defeating the therapist that we've all heard many times before. And he would, oh, hang on a minute. Can you just go back to that? He would say it like that. And he would interrupt frequently, but it was not rude. And it had this way of saying, you said something there that I really want to focus on. And it says without saying, this is where we need to go, right? So we know with people with NPD, you let them teach you. Well, that's sort of the trick, as I understand it, of MBT, is that you exhibit genuine curiosity, but only about as real and only about what you don't actually know. And I used to be an elementary school teacher and middle school teacher, and my mentor told me when I was first doing it, he said, never ask a question if you know the answer, right? And I think that leads me into the second part of this, which is the not knowing stance. Now that term, there's a lot in that, and Gwen is going to describe it much more deeply than I will, but I'm just going to talk a little bit about my relationship with that. When I went to the training, this was the thing that I took away and found most useful. Because if you've been trained in MI, you know that you guide people towards a specific conclusion, a healthy adaptive behavior, right? Maybe, stop using heroin. It's harming your life, harming your family. So you're not directing them, but you're guiding them. With the curiosity and the not knowing stance, which is just, I'm going to ask you a question. I'm genuinely interested and I really don't know what the answer is. That's been good for me, because I have a confession to make. I sometimes ask questions with the tone that I know the answer. If I feel like I'm trying to lead someone toward a healthy decision, or it's obvious that they're contradicting something they've said earlier, then I will sort of try to guide them that way. And I'm almost anticipating their answer, and it's either the one I want or the one I don't want as a therapist. And I found that just doesn't work with some of the more treatment-resistant clients. So that's why I wanted a different form of sort of getting in there of inquiry. So I want to keep this moving quickly. I'm going to jump into a brief I'm just going to do a quick case presentation of someone that I really struggled with. So this is a young man named David. I'm very curious to see, his name's obviously not David, and that's a doodle I did in an art class, not him. But he's a 28-year-old guy. He's a cis gay Jewish male, severe NPD, narcissistic personality disorder, severe OCD and depression, and really thinks he has undiagnosed autism spectrum disorder. This client came to us and sort of hit, we have over 100 clients in this setting. People are very supportive. It's a wonderful milieu. But then when he came in, his level of acuity it was just different. And he would dominate the groups and he would shout. And, you can see that there was this nice guy underneath there, this humor and wit that you'd try to crack a joke with him, and like the edges of his mouth would curl up for a second, and he would realize, no, if I laugh, you're going to think that nothing's really wrong with me, and you're not going to understand what's going on, and so I'm going to stop myself from laughing. He had this very particular habit that everyone here who was in a group with him empathized with and found off-putting. If I can speak for everyone, I guess I can't. I will speak for myself. I found it annoying. I cared about him and wanted to help him, and I saw him as the biggest block to our work together. He would go through this thing where he says, and here's the OCD, he would come in and say, my life is ruined. My life is ruined. My life is ruined. He said it to me yesterday, probably one time per second for 10 minutes. So probably about 600 times he said it to me. And I was thinking, okay, what would Anthony Bateman do? And he would interrupt. So say, well, hang on a second. Can I jump in there? And I tried that a couple of times and he wasn't having it. He would just talk over me. So I'd let him vent for a second and then I would jump in again. Okay, now, so can I ask something? And again, he wasn't having it. And I tried to pick the hardest client I could for this, because he's really been a struggle for me personally. His parents are happy with the treatment. He says it's going decently, but he is convinced that nobody has ever understood him and nobody ever will. And the trap he got all of his previous clinicians and me into was, he'll say, my life is over. It's never going to get better, right? And if you don't agree with me, and if you don't say it back to me in the exact same way I'm saying to you, I'm going to assume you don't understand and I'm going to start shouting. And he does shout. He'll shout in a way that other clinicians will come see if I'm okay. He's never been physically threatening, but he bares his teeth. We see his canines. It's frightening, and the volume can certainly be triggering to anyone who's had any sort of trauma, and it has been. So, when he's going through his my life is ruined over and over bit, it's very tempting to interrupt him and, and say, listen, you're this white, tall, good-looking guy, you're young, you're from a wealthy family, you have so much going for you. I understand that doesn't, invalidate the pain you've been through. That pain is real. Can you stop for 1 second to look at it from another perspective? That would never work with him. People have been trying that for 15 years with him and it hasn't worked, right? And so I tried the NBT. I tried it a little bit with him. If I could get a word in, I was thinking he needed to cry, and this happened just yesterday, and he looked like his voice started shaking as he was saying, my life is ruined, my life is ruined. And so I was like, well, what's going on for you right now? And then he started crying, and he cried for a while, and And then we wound up having a healthy session in which he opened up and was actually able to talk about a few things. I've been working with him for some months now. When he first came in, we had an issue in which he came in and he said he's not going to be able to find the exact lineup of the Nickelodeon shows from 1998. And, how can we possibly, how can I be okay that I'm so upset? He has some insight. He knows it's sort of ridiculous to be upset about something as specific as that. And he knows it's okay to want to do a little adaptive regression and give his inner child a hug. And he was very young in 1998. And he wants to experience that. And I know he's taught me not to say, how about we look that up together on the internet? Or I just ask him more about it. And I truly am curious. There's the not knowing stance is I don't really understand what it is that makes him so sad about that. I know what it can make some people to feel disconnected from that part of their life, but I don't know what it is for him and how that connects with his story. So anyway, I learned, he asked me this question, how can I be okay with being this sad? And I have he is on the spectrum, and I have a nephew who's on the spectrum whose older brother is not. And so my older nephew who's not taught me to ask, when the younger one says, how do I handle this? The one who's not on the spectrum, rather than answer the question, says, what do you think? What do you think? So I sort of have been doing that with him. So a combination of MBT and what my nephew does. And he'll answer it. So basically the short version is sidestep what is not mentalizing, right? When he's shouting, he's not mentalizing. And in this case, yesterday was the worst he's done in a while. And I think it was because he was home and regressing. But when he goes on a rant about how his life is ruined, I would just, one intervention would be, let's go back to your question. And he has said many times, it's true, my life is ruined. It's never going to be how I expected it to be. And I have reason to think it never will be. So if that's the case, it's never going to be, then how do you go about being a tiny bit happier in light of that? And I was gratified to hear he told his parents that I was the first person who understood him. I don't really understand him, but for whatever reason, the MBT technique was effective enough that he felt heard for the first time in 15 years of therapy. Now he's still unemployed and still unhappy. So he's far from a success story yet. I do think he's moving in that direction. So I think, was that my last slide or did I have another one? I think that was the last one. So I will pass it now to Gwen. And Gwen is going to do a deeper dive into MBT, and I'm really looking forward to hearing it.
Thank you, Jeremy. I really appreciate that. So I'm Gwen. I'm a trained MBT practitioner. I use MBT at Cornerstones with all of my patients. And today I want to go over what exactly mentalizing is. I want to give you guys an overview of the MBT process and kind of explain how I use it. And then I'm also really excited to share with you how we've adapted MBT for use with our non-clinical staff. I think that it has been something that's really helped us address some really challenging clients and challenging situations. So mentalizing is an ability that we all have to understand the mental states, both of ourselves and others, that underlies our thoughts and behaviors. This is really, I think, an important concept because we all have the capacity to do this, and mentalization-based therapy is really designed to facilitate that. So mentalization-based therapy is an attachment-informed approach that was originally developed by Anthony Bateman and Peter Fonagy to treat specifically borderline personality disorder. MBT really, I think, is meant to support individuals to really be able to understand their own thoughts and behaviors, and then be able to understand and respond to the thoughts and behaviors of others. This is a really critical process because what we find, I think, with many of our treatment-resistant clients, and I'll go into this in a bit, but is that when they're not mentalizing, that's when we see things like acting out. That's when we experience our own challenges with countertransference. So I've really found immense gratification and even my own sense of satisfaction in being able to learn to mentalize myself and be able to help my clients be able to do so. So in mentalizing, there are 4 key processes that as an MBT practitioner, I'm looking for and I'm evaluating and really also trying to help alter through the therapy itself. So the first process is really the integration of the self and the other. This process is really the ability to consider and adopt the perspectives of the other to the self, and really reduce our sensitivity to how others perceive us, and reconcile this with our own perceptions. So this actually really pulls from an approach that is psychoanalytic and psychodynamic, right? We really want to understand about identity formation, how we understand ourselves, how we see ourselves. And our identities are really a culmination both of our perception of ourselves, but also what's reflected back at us from other people and how we make sense of it. So MBT really seeks to help integrate those two things. The next process is automatic implicit processing versus controlled and explicit processing. So we really want to help our patients to move from an implicit way of thinking to more explicit. So really the ability to challenge automatic assumptions that people might be making, becoming more flexible in your thinking, and to make our implicit thoughts explicit through process, which might be sharing with someone else in psychotherapy or in conversation our experiences. So it's really about moving from that implicit state to that more explicit state of processing. Next slide. So the other function that we have is the internal function and the external function. So this is really our ability to challenge superficial judgments that we might be having based on what we see, and to consider other possibilities that are external to us, right? So we really want to move and help our patients move from a place of that internal functioning to something that's more external and more in consideration of the world around us. And then we really also want to be looking at balancing out cognition and affect. What we see a lot with our patients is there's like a splitting of cognition and affect. And this is really something that can become quite problematic, right? And we see this in patients who are certain of situations. We really want to help reduce that certainty, increase flexibility, and then really reduce the disconnection of pure cognition. And really an integration is what we're seeking. We want our patients to have a balance and of thoughts and emotional experiences about how they see themselves and how they see the world. So the other part that's really important to consider is that while we all have the capacity to mentalize, we also all can fall into a non-mentalizing state versus because of stress that we might encounter. So we all need a little bit of stress to mentalize, and Lois Choi Kane at the Gunderson Clinic talks about this a lot. Actually, the ability to mentalize based on stress, you need enough stress so that you can mentalize, so that you're stimulated. But at a certain point, the stress becomes too much, and that's really what we call the biobehavioral switch point, where the part of our brain that is thoughtful, able to really think and plan and have more of a controlled experience, with enough stress, it switches over into like automatic processing, right? And we act out of pure emotion. We might be impulsive. We let our emotions and those implicit choices kind of guide our behaviors, right? And this is really important for us to consider, because this is not just true for people with BPD. This is true for all of us, but even more so for people that have trauma histories, struggle with depression, anxiety, other personality disorders. And so when it comes to challenging clients, the most challenging situations are those where that biobehavioral switch has been flipped and they're in this very non-mentalizing mode. And that's when you see a lot of acting out. That's when it's challenging for staff to be able to address situations like a client yelling and screaming because they didn't get what they wanted or they don't feel heard. All of these situations are really coming out of an aroused state based on too much stress. So in these moments, it's really important for us to be able to recognize them, because, you know, if we try to address those situations in a confrontational way or try to reason with someone who's in this state, we're going to be unsuccessful, right? And so mentalizing is really looking at how do we support this person to be able to calm their stress system, be able to move back into a place that is rational and controlled and thoughtful, and do so with empathy. I think a lot of our patients who are in this state of arousal, they're hard to have empathy for, because they're saying things to us that are offensive or disrespectful. They're really unregulated in themselves. So, you know, it's easy for us to become a little dysregulated too and trying to address them. And I think the hope is that by understanding where this comes from, we can approach it with some compassion. Next slide. So Anthony and Peter came up with 3 official kind of non-mentalizing modes. They're very British. I'm going to kind of go through them. And to be honest, it took me the better part of the last 2 years to really be able to understand these non-mentalizing modes and be able to like see them in action in therapy. So if this feels a little deep and heavy, I apologize. And you know, I'm definitely willing to answer questions at the end of the talk, but I'll go through them. So pretend mode is the first non-mentalizing mode. And really what that looks like, it looks like mentalizing. But for a person who's in pretend mode, really there's a very specific disconnection from cognition and affect. So this may be the best patient you've ever had, right? They're able to take in therapeutic concepts, they can repeat them back to you, they look like they're making progress, but there's no integration. There's no way that they're able to integrate what they're learning into their own affective state because they're so separate. Excuse me. So that's one of the hallmarks of non-mentalizing, right? Is that disconnection of those 2 states. The next mode of non-mentalizing is psychic equivalence. For people in psychic equivalence, feelings are really facts. You know, you'll find that a patient who's in psychic equivalence is very certain about how they're interpreting a situation. And they may say something like, I know you don't like me and nothing you say will change my mind, right? We find that very black and white, rigid thinking. Teleological stance, which was the one, honestly, that was the most challenging for me. But for teleological stance, our patients are really very concrete. They require a lot of evidence to be convinced or to demonstrate to someone how they're feeling or what they're experiencing. So you may find someone in a teleological state say something like, you didn't call me like you said you would, and that's how I know that you don't really like me, right? They need that evidence to be able to understand, or they'll use evidence to make their point. Next slide. So when we look at non-mentalizing with challenging clients, we're looking at it both in our clients, but also in ourselves and with our staff. A hallmark of MBT is that it really does require both the clinician and the patient to be mentalizing. As the clinicians, we need to start the process and really kind of be one with our own mentalizing. A trick that I use is I will ask myself 3 questions. I'll ask myself, what am I feeling right now? Why do I feel it? And then how might this influence my behavior or decisions that I might make or my thinking, right? And if you ask yourself those 3 questions, you're mentalizing. So it's something that we have to kind of internalize and start first. And Peter Fonagy and Anthony Bateman, they always say mentalizing begets mentalizing, right? So we start mentalizing ourselves as clinicians, we demonstrate it, and I'll talk about that in a minute. And then we're able to facilitate that in our client and then be able to manage that throughout the session. But so when our clients are not mentalizing, this will look like defensiveness. It'll look like mind reading. It'll look like being convinced that they're right or trying to convince others that they're right, trying to control a situation so they don't have to experience an emotion, being inflexible in their thinking, arguing. Sometimes sessions when they're heightened can feel like arguing. Patients feeling frustrated and unheard or disrespected, or keeping their true feelings and thoughts hidden from others, right? And it's about protection. When they're in these triggered modes of non-mentalizing, it's about trying to protect themselves for what they perceive might harm them. And then in clinicians and staff, this is what I see a lot, and I will be honest, I experience this sometimes when I'm not mentalizing. It might be taking a client's language or behavior personally, right? I've had some really horrible things said to me, both in session and the milieu when someone's really triggered. And sometimes if I'm not mentalizing, it's hard to not take it personally. Getting caught up in debates over rules or consequences. I observe this all the time. It's something that happens frequently. Not being curious about a client's perception or their experience, right? This is something that I'll talk about when we talk about more of the not knowing stance. Also taking the expert stance. I find that some clinicians in supervision, I will notice, oh, you assume the expert stance because you might be triggered by a client feeling like maybe you're not good enough or you're not a good enough therapist. And so when we feel that way, it's easier to take on that expert stance. It provides us, I think, a certain cachet, a certain amount of implied respect, to kind of handle someone who is acting out. I also see compassion fatigue when you're not mentalizing, taking things personally, trying to manage someone who's dysregulated is really hard. Unacknowledged countertransference. This is a big one. Mentalizing, when we're doing it, we're able to acknowledge our countertransference and be able to work with that. So I think it's a really key piece of that mentalizing process. And then also just missed opportunities to connect with our clients. There are a lot of opportunities to be curious about someone's experience, to validate them. And when we're not mentalizing, sometimes we miss those. And it's a unique opportunity, I think, especially with the clients that we treat. I don't know how often they've had really fulfilling connection. So we want to capitalize on those as much as we can. Next slide. So the MBT process, I've broken it down into 4 steps. This is generally how I'll use MBT. But of course, I think that in different organizations, in different types of treatment, MBT can be broken down a little differently. But with our residents, this has really been helpful. So Jeremy talked a little bit about the not knowing stance. This is really important to Fonagy. Fonagy indicated that this approach in any therapeutic interaction is meant to be based in curiosity rather than approaching the interactions as the expert. This is important because it really allows the clinician to demonstrate a healthy curiosity in another's mental state. And it also allows the patient to be the expert in their own mind. So by taking the not knowing stance, you're actually modeling mentalizing for them in a way that is safe, is intentional in the therapy, and really allows them to start opening up, asking a lot of intentional questions, as Jeremy stated. We also want to work with empathic validation, right? And this is something, Jeremy, that I also appreciated you said, which is that it needs to be authentic. We really to approach our residents and our clients with empathic validation, acknowledging and validating that their experience, regardless of the accuracy of it or their perception, is real to them, right? And instantly that can provide some comfort to a person to know that you're listening and that you're willing to understand them and really validate what they're going through. And it does require us in some ways to put ourselves into their shoes and really access within ourselves that same type of pain, that same type of longing, that same type of loss, to really understand them. And then we want to be sharing and challenging perceptions. So what you want to do is really be inviting the client into your own mind as a clinician. So being curious with them, can they understand how you might view a situation? And really considering them to, consider the perspectives of other people, right? So a client might be talking to me about a fight they had with their boyfriend, and I might be curious with them, do they have any sense of where the boyfriend was coming from? Do they have the capacity to be able to think about someone else's thoughts about a situation and really take on that perception? And really also wanting to look at engaging the patient in the session and what's happening in the here and now. So I'm going to be curious if my patient is upset with me or how they're feeling based on something I said or something I asked, and really being curious and present in the here and now. That's really important. And then what we're looking to build through this process is epistemic trust and collaboration. So epistemic trust is really the ability for our clients to have the willingness to consider new knowledge as trustworthy. And this really goes back to how MBT is a very attachment-informed way of working and seeing the world. We really want to build in them the ability to regulate with us and to be able to take on new information, be flexible in thinking, and really work towards understanding that through a therapeutic rapport, we're able to challenge our perceptions and our assumptions and view the world in a different way. Next slide. So as we've adapted MBT for use with our non-clinical staff, we've divided it up into 4 different interventions. As you'll see, these are very similar to the MBT interventions that I had just mentioned, but I'll talk about them a little bit. So we want to encourage all of our non-clinical staff to approach situations with curiosity, asking a lot of what questions, a lot of how questions. We want our staff to validate our clients' feelings and acknowledge their perception. We want to ask permission and have our staff ask permission to offer their own perceptions of a situation or their interpretations, and then collaborate, say, what can I do with you right now to help resolve this? The benefits of this is that, one, it supports mentalizing in our staff. It reduces reactive responses when our clients act out. It cultivates trusting relationships with our clients and staff. It helps retain clients. That's always important. It supports the health of the milieu, and it really supports the therapeutic goals through less clinical interventions that are done by our RAs and our life skills staff and all of our other staff. So we've really found that, I think, to be really helpful. So Josh is going to take over now and share with you guys some other complementary modalities, and I really appreciate your time.
That was excellent. Thank you, guys. It's important work, and the way I look at MBT is helping our clients become observers of themselves. And MBT came from, correct me if I'm wrong, psychoanalysis and people who study psychoanalysis. So it really is complementary when it comes to preparing someone to be insight-oriented, to taking a look at themselves and the relationship. So, the basis, I'll be kind of short with all this, the basis of psychodynamic or psychoanalytic theory is that there's an unconscious. This iceberg kind of shows you may have seen things like this before. The conscious mind is the top, the preconscious subconscious is kind of the middle spot. And there's a ton of space that's just out of our awareness. And it's based on a lot of information that we receive in life and experiences and conflicts. And when we're really overwhelmed, we tend to stuff things down and repress and regret and suppress and all sorts of ways to manage being conscious. You can switch this slide. Freud talked about this concept of the repetition compulsion, and that is so he called it a psychological phenomenon in which a person repeats an event or its circumstances over and over again, putting oneself in a situation where the event is likely to happen again. So we can't just push these conflicts away, as hard and difficult as it might be. They always come back up, and oftentimes in an unconscious motivated way, they get reenacted with the therapist, with relationships, with families, with if you're in a milieu, in the milieu. And so, we in our environments have a really great opportunity to get these details, because it's not just someone coming in for 45 minutes a week. You observe them their whole day, their whole week, months, even a year. You can really get deep into some complex intrapsychic materials. You can switch the slide again. So this is an example, conscious level thoughts, perceptions, preconscious, subconscious memories, and stored knowledge. We have these things that come to consciousness and then quickly retreat and move away, just giving us enough to kind of tolerate our conscious existence. And then you have the unconscious level of experiences and parts to ourselves, immoral urges, selfish needs, shameful experiences. We all have everything we see out there. We're all capable of all the horrible things, all the great things. They're all stuffed down there in the unconscious, so we can live with ourselves. Not that and the healthier people out there tend to know how to treat their community well, and not act on those impulses or those urges that might be deep down inside of us. Thank you. So what we do is we defend against those very difficult, challenging conflicts and parts to ourselves. Valiant talked about these 4 levels of defenses. So the ego is believed to be the thing that determines what we get to experience and what we need to suppress. It protects us from all these parts of ourselves. And so, that the higher the level, the more mature. So, humor, sublimation, suppression, we tend to use these things to kind of deal with uncomfortable situations and parts of ourselves. A little less maybe healthy would be becoming more neurotic, intellectualizing, repressing, displacing. Level 2, you'd see much more in these axes to borderline, cluster B diagnoses, passive aggression, projection, devaluing, idealizing. And then level 1 is actually, I don't even want to touch on that too much, but you can see that's a really underdeveloped ego, and the challenge in one's ability to really integrate the fullness of themselves. If you go back to the person with narcissistic personality disorder, They're just a small, a half an inch away from borderline organization, and they will regress to that point when their ego isn't functioning in a way that they, that might be more as beneficial for them. You can change the slide. So, what we do in psychodynamic work is we want to observe the object relations, the relationship between the caregiver growing up, what's been internalized, what the environment was like, and how one's identity is formed in that way. Developing clear histories, determining patterns. And that's the great thing about being in the milieu, being in our treatment programs, is we can see these patterns reemerge over and over again with different people at different times. And I was saying, if it happens once, it might be by chance, happens twice, maybe. Third time, definitely not. There's a pattern there. And we tend to see that. And then observing defense mechanisms. Like I mentioned before, when you see those things arise in a person, when a client splits, their family from the program, or the consultant from the parents, or whomever it might be, that's actually, no, that's more literal. Splitting would be kind of an all good or all bad object. So they can't tolerate seeing someone's both because they don't know how to manage the two together. And part of this work is helping our clients integrate, these different representations of themselves and others. So exploring transference, countertransference, and projected identification, those are very valuable in psychodynamic work. Transference is what the resident or client, patient, projects onto the therapist or milieu. Countertransference is kind of the reactions in the therapist to the client, and projected identification is what the client projects into the therapist, and the therapist then feels. An example of that, I'm thinking about when I learned what that term was, about therapist was seeing a child, and the child would come in to the therapist's office and would dump over her purse every time. And eventually she said to the child, hey, in terms that the child can understand, you make me feel, hurt. You make me feel, exposed when these things happen. And it led to the child being able to voice what was really happening to them in their life. It was making them so hurt and upset. So using that information of what we experience, we can often, if you're trained, in that, and if you understand what your triggers are and, what your kind of transference tends to be, we could use that information and really get further along in treating our clients. And MBT really goes well hand in hand with the psychodynamic work. And so it's a really neat combination. And I will stop there because I want to leave room for questions, and that was not a good job taking all the psychodynamic analytical work in the world to 9 minutes, but that's what I got today, and thank you.
Well, I just want to really thank you, Jeremy and Gwen and Josh. That was a wonderful presentation, and it's so great that we can train ourselves with these modalities like MBT, so that we don't have to necessarily understand our clients. We don't have to even always like them. But if we are trained ourselves, we know how to treat what's going on and can ensure a better outcome. We might not be able to fix anybody, but we can get to better outcomes. And really just want to open it up to see if anybody has any questions about any of what you guys presented today.
This is Dave Cunningham, and I was just curious. I've got some clinicians that I had sent this information on MBT to, currently dealing with a borderline patient and in residential treatment. What is the best avenue for training on this modality, do you suggest? Because I want to be able to share that with them.
Dave, that's a great question. And so the Gunderson Clinic at McLean Hospital offers annual trainings. They partner with the Anna Freud Center, and they offer introductory MBT classes with Anthony Bateman, who is fantastic. Jeremy, he did a great impression. So they're a great resource, and there is a slide with their website information so that you guys can look at that. The Anerfoid Center also offers trainings, but they're located overseas, of course, but many of their trainings, because of COVID, have been offered online. So that's a great place to start. And then also Menninger frequently partners with Peter Fonagy. They're also MBT trained, and John Allen, I think, has really played a huge role in that. And they're also a great resource. So I recommend checking them out too.
Well, they've just went through all the NARM training and really love that, and are integrating that into our residential program for substance abuse. But they're real interested in this, and if hopefully we'll get those slides, I can share them with our clinicians. I appreciate it.
I have a question for any of you guys. You all sort of mentioned what it's like to be the clinician on the other side of a client who's dysregulated or just very much in their own process. But oftentimes this happens in a group setting. And I know group members can sometimes become very alarmed or irritated or upset. And how would you say that this model would help you to, keep the group engaged and or calm?
I can take a stab at that. I remember when Anthony Bateman trained us, and David, I highly recommend the Anerfoid Center. They were excellent. The way he described it was this works very effectively in a group, and we watched some videos of it, and I think he would model for the clients the interrupting and refocusing in a very curious, compassionate way. The sort of like it's as if someone is sharing a screenplay they wrote or playing a song they wrote, and like they want to talk about this one thing, and you're like, no, I want to hear about this thing right here. It's a way of, it feels a little bit, it almost feels disrespectful, but it's actually quite respectful. It's like, I really want to hear what you have to say. I think you've gotten away from this, you have this undeveloped thought here. And he would do that to the point that the group would then start doing it to each other. They would say, now hold on a second, I don't think you're mentalizing right now. They would use terms like same as Gwen, I found the teleological stance a little bit hard to grasp and explain. You get it after a while what they mean by that. And I just translated it into my own language. It's people who are kind of, being rigid, being stuck, being defensive, being in some ways sort of intellectually dishonest. And the pretend mode, we can all know what that is. That's when a client is kind of just, giving you what you want to hear and not really doing any exploration. And the clients can really call each other on that, because they all people get bored in a group if a person is monopolizing with nonsense and there's no depth to it. And so they get used to that, and you start to be able to recognize it, like what Gwen talked about, it making it explicit. You can, is a person right now mentalizing? And it when you see it. You can see a person who is deep diving, and yeah, it does beget more of the same. You see someone opening up, it gives permission for others to do it. But that's what I would say to that.
Thanks, Jeremy. There's a question in the chat for anyone who wants to take a stab at it. How do you approach using this modality with a client? Do you teach them the theories behind MBT similar to DBT skills, or is it more of a covert approach from the therapist? The therapist is only conscious of practicing and not sharing with the client?
That's such a good question. When I was first learning MBT, I was covert about it because I didn't feel super confident in it. It's a complex modality. But what I found now is that actually the residents at Cornerstones are hungry for psychoeducation. They want to understand what you're doing. They want to partner with you. And I actually find for my own practice that it is a collaborative process. I'm teaching them about mentalizing as we're doing it. And they start to use the language, which is like really cool to see. Anthony Bateman and Peter Fonagy also did design this to be a collaborative process where you are intended to share with the client what you're doing. And actually it is quite manualized in their setting. So you will create a conceptualization of them using an MBT lens, you'll share it with them, and then you're always teaching and then also facilitating mentalizing in a session.
That's great. Thanks, Gwen. There's one more question in the chat. Does it frustrate clients to keep reorienting them back to their own experience when they want to externalize? How do we respond to that frustration?
Go ahead,
Sorry, go ahead, Jeremy.
Well, I was just going to say, I haven't found that it does frustrate them because it's active listening. You're reflecting back to them what you heard and wanting to really understand it more. So if they're getting frustrated about that, I don't know why they would, unless it's just a manifestation of defenses that you're getting close and they're feeling exposed. So I could see them getting a little frightened if you did that, and it might express itself in frustration. What would you say to that, Gwen?
Yeah, I fully agree with that. I think, and also what MBT would encourage you to do is then talk about what's happening in the here and now. Like, oh, are you frustrated? Is that what I'm perceiving? And talk about why, right? It's all about also the interactions. Anthony always recommends pulling the focus into the here and now and understanding what's happening in the room, because that's where the mentalizing is happening. It's not happening outside of the room or in the past or what might happen in the future. It's happening right now.
And if I can ask a panel-to-panel question, Josh, I'd be curious, how would you respond to that from a TFP perspective?
Well, I think, that frustration, it depends, yeah, I don't have a good answer for that. I think when, frustration can, I wonder if it's a therapist acting out towards the client, if it's a client acting out towards the therapist, if it's a natural kind of misunderstanding, but ultimately I think, from a TFP, that's a transference focused psychotherapy model. The feeling is really you're focusing on that relationship and there's that undercurrent. So you want to listen and learn, a little bit about the client, being curious. And that's great about MBT, is you've done that work with them and you're building up that kind of ability to hold that space. And when there is transference, a projection onto that therapist, or countertransference, the therapist feeling something towards the client, the therapist has to be able to recognize what's their own stuff. If I'm frustrated with this person, is it because they remind me of myself? If it's someone with narcissistic personality disorder, is it because they don't recognize my importance and my value? I've worked hard for my degree, or is this something that I see everywhere and all along the way? And yeah, that hits me a little bit, but ultimately this is just this need to make themselves feel more valuable, important, and you can't possibly solve the problem. So the frustration can be deeper than just frustration. And then of course, projective identification would be like, if I'm feeling frustrated, then maybe they're feeling frustrated and I need to dig deeper into that and reflect that back to them.
We do have time for one more quick question if anybody has.
I actually have a question about MBT and DBT. I've had a room full of young adults with DBT training and zero application, and so I was a little skeptical of MBT in the sense where if you're outside of a treatment program, how are you going to use DBT if I'm observing people having been in treatment programs not utilizing DBT skills? And that's not a dig at DBT. I just think there's a lot of DBT providers out there and a lot of people who don't really use it. So how, can you mail it in when it comes to MBT like you can sometimes with DBT? And again, I'm open to call me out. I don't mean to offend anyone who's a DBT specialist, but that's what I've observed.
That's a good question. And so DBT is a very complementary modality to MBT. I think a big difference is with MBT, we are less teaching skills and more creating awareness about a mental process, and supporting a person to more easily access a mental process that is healthier and balanced, as opposed to like using skills to modulate emotion or self-regulate, things like that.
Yeah, and I really agree with that answer, because I think for the client that I was talking about, I kept trying to get him to go into DBT groups. The skills definitely would have benefited him. He was just completely blocked to the process and was not going to let them benefit, because to show any progress was to sort of discount and dismiss all the suffering he'd ever done. So he needed everyone to admit or agree with him that he was unfixable first. And MBT, I think, is the way to sort of remove those obstacles. And then, okay, DBT, let's actually, now that you're asking the question of what do I do when I'm upset, now let's come in with some concrete answers.
Well, again, I really just want to thank you, Jeremy, Gwen, and Josh, for making this so approachable and for your honesty as well. Now, I will say that we will be sending this out to everybody. More than likely, it will be tomorrow, not tonight. And we do invite everybody to come back. Our next roundtable is going to be on June the 3rd, and we're going to be with Dr. Eric Placoon from Austin Riggs. That's going to be a very interesting topic, taming the wild west of managed care. So, ultimately, we're trying to help clients get more coverage, and he's got some great ways to make sure that we're able to do that as providers. So thank you guys all so much for joining, and I'll be sending an email out. So any questions you have that weren't answered today, feel free to respond, and we will see you again soon. Thanks again.
Thank you all.
Thank you.
Thank you, guys. Good job.